Uh, from Peshawar to all those colleagues who are listening me, a very warm welcome, and particularly Professor Salman Sharif, that you are organizing these activities from Pakistan side. I must welcome Professor Turel, and there is a long contribution of Professor Turel. He's a well-known neurosurgeon from India. There is no doubt that he is a professor and he has shared so many time. You see, he has a lot of contribution both in the research line as well as he is a very good speaker. And right from my young age, I must say that I love to listen him in every national and international conferences. I visited India 2 times, and I found him very friendly and just you see a senior colleague, and he was always giving some points of you see of neurosurgery to be introduced and to be practiced in coming future. I met him so many times in international conferences. He is the author and he is the you see he's a sort of model of neurosurgery, not only for me but when I have listened him every time I have learned so many points. Today, I welcome him from the court of my heart, really from Peshawar and from Pakistan. And it is a great opportunity for me to introduce and welcome Professor Turel. When I see him, he is just like Karachi people. You see the way he love that. Professor Turel, if I'm not wrong, you have given me a few videos as well to how to control the bleeding from the dural edges. It was in some 20 years back, it was a difficult point for me. So apart from that, he has shared so many different topics and controversial points. We think he has crossed that age. He is very dynamic and he is very active person. So welcome, Professor Turel. And we have so many colleagues here in Prime Teaching Hospital, and we are listening and we are waiting for you. Thank you very much.
Thank you, Ahmad. I've been to so many international meetings, but I've never had such a beautiful introduction to me as you're given today. So I'm really flattered. So can you hear me?
Yes, yes, we are hearing you. Yes.
Yeah.
So you can start, please.
Thank you for this great opportunity from our brothers across the border. We are really very honored to be able to address our colleagues, or I would call you our brothers from across the border, to be able to participate in this. Now, Salman has very rightly and wisely asked me to talk on complications, because that has been the subject which has been close to my heart for a very long time, for many years. And because I myself saw so many complications during my career, I realized that in most of the meetings, when presentations are made, everybody talks about how good he is and how great he is and how I do it and how brilliant the results of everything are. And towards the end of the session, just one quick slide is put in, and these are the complications and conclusion. So very little emphasis has been laid on complications. And this is why I thought it was time for us to start becoming a little more frank. And our greatest learning comes from complications. We don't learn anything from success. We only learn from failures. But that also we must be prepared to learn. So there we are. So first of all, let me say namaste. This word namaste comes from the word na-mas-te. My soul honors your soul. I honor the place in you where the entire universe resides. I honor the light, love, truth, beauty, and peace within you, because it is also within me. In sharing these things, we are united, we are the same, we are one. Bye-bye. Yes? Wonderful. So namaste, one more time. And this namaste, I must tell you, now has become an international norm with social distancing. Nobody wants to shake hands. So in this coronavirus, we have to say namaste only. You can do salam, of course.
Keki, can you share slideshow, please? Can you put this on slideshow?
I'm going on to the next one. Yes.
Can they see it?
If you just put slideshow.
Not moving further. No, Big slide. On the big slide. Yeah. It's not moving. You are seeing the first slide, are you?
Yeah, but we just need to do slideshow. Maybe you can pull it up slightly.
Yeah, but we remove that now. It's not moving from there.
Okay.
Yeah.
Doesn't go.
If you just do a right click on it and then just it says zoom screen and zoom it. Right click it and it says full screen. Right click on it on the thing. It's not letting me. Or you can pull your whole of the presentation slightly up and then you'll see it at the bottom. So just make it small. Just pull it, go on the green button on the left, green button on the top left.
On top left, okay.
Yeah.
Yeah, all right.
Yeah, this one, just click on it.
Click on it, yeah.
So it becomes small. No, so now can click on it once more time. One more. One more time. Basically, you need to drag it from below up to able to see the slideshow thing. You can do it from here as well.
Yeah, but we can't do it.
Okay, if you have that much trouble, what you could do is you could just enlarge this picture.
All right.
Yes, if you go on the top, come on the top, slideshow on the top, on the right, come on the right, come on the right, bring your thing on the right. After animation, before review on the yes. Bring it there, bring it slightly, yes, go up, go up, go up. Again, go up, bring your cursor up.
I think
Bring your cursor to the right. Bring your cursor to the, yes, just push there. Yeah, no, you need to push on slideshow. Push.
Is it?
Slideshow, here.
We are already there.
Yeah, we are already on slideshow.
It's not allowing.
Okay. I'm not sure what the problem is, but let's get on with it. Otherwise, we are.
Move. Yeah, okay.
Yes,
all right.
Good. You got it. Well done.
Yeah. Okay. All right. There we are.
You have 95 people already listening to you.
Thank you. So, how to deal with complications in neurosurgery? My official time starts now, Salman.
Yes, definitely.
So, as I said earlier, I have no other disclosure but to say that I have seen all complications in neurosurgery. Definition of complication is derived from the Latin word complicare, or fold together. It's a secondary disease or condition which makes an already existing one worse, something more intricate, difficult, or confusing. An unfavorable evolution or consequence of a disease or health condition or therapy. Sequel, on the other hand, is continuation of an earlier event or an after effect of surgery that is inherent to the procedure. For example, pain, inflammation, vomiting, these are natural sequelae after surgery. These are not complications. So sequel is a pathological condition resulting from a prior disease, injury, or an attack, like hydrocephalus after meningitis or subarachnoid, or weakness or wasting of a limb following poliomyelitis, or hair loss following radiation chemotherapy. These are sequelae. Now, how will you term these not so infrequently experienced events like intraoperative aneurysm rupture, brain edema following tumor removal, seizures during awake surgery, or Teckel syndrome following removal of posterior third ventricular tumor? Are these sequelae or complications? And how will you term excessive bleeding during surgery? But let me tell you, trying to remove that last bit of meningioma adherent to or invading the carotid artery, that certainly is a misadventure. Should not be done. Similarly, a hole in the ICA during transfemoral surgery or puncturing the basilar during ETV are disasters that should never occur. So sequel or complication are two different words. There should not be no confusion between the two. And our patients need to be informed or forewarned of the possible events that may occur during or following surgery. This clarity in our own minds will clear the air between our patients and us. Very often patients ask us, doctor, you're going to operate. What is the guarantee? How much will do tumor removal you can do? I always tell them, remember please, medicine is a very uncertain field. There are no guarantees. I'm very clear about that. Knowledge and experience. We all have knowledge and we all have experience, but individually they have limitations. When combined together, knowledge and experience is wisdom. And as you can see in very small letters, wisdom is very hard to find. Not easy. In medical practice, mistakes are not allowed. We should be very careful not to make them, and they are seldom forgiven. And a very clear example is here. This is a tombstone of a patient who was a deputy superintendent of police who died. And on the tombstone is mentioned, died due to negligence of this hospital and this doctor. Can you imagine? It is better to be etched in the memory of people than on their tombstone. Every medical field has complications. Complications in neurosurgery can be really very devastating. They are an unfortunate part of surgery, which makes the consequences worse than the original disease. And it may bring great suffering to the patient and his family, and also tarnish the reputation of the surgeon and of the specialty at large. Complications can be intraoperative or postoperative. They can be surgical or medical. So two sides of the coin of complications is anticipation or prevention, and on the other side is management of complications. This management can be immediate, that means during the procedure itself, or it can be late. It can be concerning the patient, or it can be concerning the family, or dealing with the family. And therefore, since we are talking about anticipation and prevention, remember 5 Ps. Proper planning prevents poor performance. Plan your operations, plan your procedures, and there'll be a good performance there. So this planning or prevention begins with the physician understanding the case. Proper history, detailed history. These days, I see young doctors don't take history. They just look at the scan and start talking. And they start planning their operation. Take a detailed history. There are so many important points. Examine the patient very carefully. Interpretation of individual scan images. Every single small square on the scan must be individually seen. Discuss it with your radiologist. So you must understand the full case before you plan. And then when you plan forwards and you plan backwards. You plan how to open and you plan also how to close before you start. And you must have a plan A and you must have a plan B. If your plan A doesn't succeed, you must quickly switch over to plan B. And this planning forward and backward must be with regard to approach to the disease. You must also determine the goal or the endpoint of the operation, whether you want to have this tumor removal complete or not. You must prepare for intraoperative equipment and usables like your ultrasound or whatever. Preparing for intraoperative and possible post-op events. Specifying and assigning the role of each team member. It should not be ad hoc, that sometime one assistant comes, another nurse comes. Everybody has got a specified role. And then you run through the checklist or the manifesto. Also, I'll come to this in the next slide, but you must remember when you're planning that the thigh has to be prepared sometimes for fascia lata, the leg has to be prepared sometimes for the saphenous vein, for a bypass, and sometimes you have to prepare the neck for the ICA control. We in India say attitude. Attitude is chalta hai, dekh lenge, we will open and see. Now you must remember this kind of an attitude doesn't work. There is enough imaging available to accurately predict and prepare yourself. My common statement, it is easier to stay out of complication than get out of complication. This happens not only in neurosurgery, even in your own life. Better stay out of trouble than get out of trouble. Anticipation helps. Prevention better than cure. Very well-known adage. It's a chakra view. It's a word used in the ancient warfare. Knowing how to get in, but not preparing for an escape route can see you get trapped. So chakra view is the labyrinth. It's a complicated, irregular network of passages or paths in which it is difficult to find one way, what we call as a maze in simple words. Many years ago, 500 BC, 400 BC, Hippocrates told us prevention is better than cure. Primum non nocere. At first, do no harm. Which means at first, you know your own limitations. What can you do for the patient and what you cannot do. When you are planning, everyone plans how to open a multi-wall skull. But very few people plan how the closure would happen. An overzealous extensive opening for a skull-based lesion and not sparing the tissue for a good closure can lead you to a serious consequence, most notably CSF leak and meningitis. I'll give you an example. Lessons learned from this complication was this patient was referred to me with tension pneumocephalus through a large unrepaired skull-based defect following partial excision of a large trigeminal schwannoma. He was a 55-year-old male. He saw me on November 11, 2016. He was operated on October 17, about 24 days earlier. But when he came to see me, he was with severe headache in upright position, drowsy, in great distress. He could not sit at all. Severe headache. He had a history of trigeminal schwannoma being done partially excised via left temporal craniotomy. This was the image before the operation. You can see the tumor going through the skull base out. And this was after the operation done in November in October by another surgeon. And you can see the amount of air. This created a huge amount of headache. And there is also a large residual tumor still left inside. Having had this experience of severe headache, they attempted an endonasal transmaxillary endoscopic approach to repair the skull base from below. After 2 weeks after the craniotomy, this proved unsuccessful. And this was the appearance after endoscopic repair, and severe headaches continued. So he was brought to me in this very condition, very unfortunately, very severe headache. Clinical video is there, but I won't show it. He was in distress. What is the video not working here? All right. So this is, we reopened the craniotomy and large bits of tumor removal, large bits of residual tumor were there. So we removed all those tumor bits and expanded the area, got a free, good, clear edge of the tumor of the skull base. And you can see now that there is a trigeminal schwannoma, trigeminal root from which the tumor is arising. That has been excised. And now you have a large hole. And how do you clear this? How do you repair this? I got an idea at that time. I said, let's put a large Foley's catheter and put an expander bulb and completely fill up this cavity with a large Foley's bulb from below. And from above, I will then repair. This repair will be maintained in place by this kind of a bulb. And then I put in a lot of fat and glue and then some bits of bones to skull to repair the skull base. I could have brought in some temporalis muscle, but that was not available immediately. And that's the way we repaired the skull base. Now, this is the appearance after the operation. Very little air now, and a very happy patient. Excellent result, and moving on freely. Very happy. No more defect, no more pain. Okay. So the next point is this WHO checklist that I talked about. This surgical safety checklist is the first edition, but you can have any modification you want. So you have before induction of anesthesia, there is sign in. Before skin incision is time out, and before patient leaves the operation room is sign out. So we have this protocol. You can download it from the WHO's surgical safety, but you can have your own protocol. But this protocol is read out openly by a member of the team who is not scrubbed up. And so they go through all these protocols, sign in, time out, sign out, and that ensures that you've ensured the full safety of the patient. Let me enumerate a few high-risk factors. The first factor is inadequate training and lack of maturity resulting in complications. And so this training is extremely important. This training is not only, it always starts with cadaver training, as you can see me doing this cadaver workshop. Then lab training, you can see me training my own son, Mazda. I'm showing him how to do a bypass on an animal experiment. And then we have finally microsurgical training in our own surgical theater. So you have to go to these 3 levels of training. You can't just come straight to the operation theater and start learning microsurgery. If you spend more time preparing, you will spend less time preparing. That's the importance of training. Second point of high risk factors is errors of anatomy in inexperience of neurosurgeon. Inexperience of surgery. This was I'll give you an example, young school teacher, intractable trigeminal pain, advised MBD by me. She has another bout of suicidal pain in my absence. She gets admitted in emergency at another hospital and undergoes MBD by an experienced neurosurgeon. However, so this was the preoperative MBD, preoperative MRI. Post-MBD, she develops partial deafness, severe tinnitus, and no relief of trigeminal pain. She consults the operating surgeon several times, given pregabalin, antidepressants, even morphine, but nothing happened. Then she came to me. I discussed with the previous neurosurgeons. He told me that he had a perfect NVC loop, neurovascular conflicting loop, and he did a perfect MBD. And he just said the patient was being impatient and unduly complaining. Now, you have an experienced surgeon and you have a very reliable patient. What do you do for this recurrent trigeminal neuralgia, who is not only relieved but has got additional symptoms? Tinnitus, deafness. Anyway, I thought I will have to go in again. So here it is, and I'm going to show this video, edited video. So I go straight to the tentorial corridor, petrotentorial corridor, and I go to the superior surface of the cerebellum, the lateral superior surface, and I find this area is completely virgin. I move my microscope down, and I load, and this is where I go. I see the 7-8 complex. What has happened? I find Teflon is the 7-8 complex, and I find the ICA loop over here. So what has happened? That instead of trigeminal neuralgia decompression, we have had a 7-8 nerve decompression. No wonder she had tinnitus and deafness. So I remove this Teflon from here, go back, go deeper. Trigeminal nerve is deeper in a lower segment of the CP angle. 7th and 8th is a higher segment. We go down, and this whole area is virgin, untouched. I remove this loop of cerebellum. Very simple operation, straightforward. Put in some Teflon there, insulate the trigeminal nerve. You can see the tentorium there. You can see the brainstem here, trigeminal nerve, superior cerebellar artery loop, and push the Teflon there. And there we are. Put some glue to fix it. And post-operatively, a very happy patient. So, error of anatomy and inexperience of the read. Next is wrong choice of patient, wrong choice of approach, wrong choice of technique. Let me give you an example of each. Wrong choice of patient. I'm going to show you most of these complications. I'm showing you my own cases, mind you. This was a patient who was referred to be by a very enthusiastic and aggressive neuro-oncologist. This patient had a GBM, was already operated, and says, no, there's a recurrence. Why don't you get this out? We have seen your cases before. They do very well. You are known for complete excision of the tumor. So why don't you do it? Well, I fell in the trap. I removed the tumor, but look at all this edema and look at all that. The patient actually deteriorated after surgery, after the second operation. Of approach. Nowadays, we say less is more. We have gone into modernism, minimalism, less fuss. So we say choose the shortest and the safest route to the region by the most minimalistic approach. Now, it is good. It is good to be minimal. It's good to be modern. Good to be less is more. We must remember, in olden times, Walter Dandy approached aneurysms by this large craniotomy. It is more easy to make big approaches, but you end up with small corridors. But what we have now learned is that from these small corridors, we go to big spaces. And here you can lead to an aneurysm very nicely through a small supraorbital craniotomy. And we have learned this from our pioneer, Axel Perneksky, a very good friend of mine, who introduced this keyhole concept in neurosurgery. So it's a very good concept with endo-assisted microsurgery. So we got on to doing this mini craniotomies by a supraorbital eyebrow approach, and we can remove this tumor and also this tumor by the same approach. Those are the cases that we have done. But if you have a case like this, how would you do it? Would you use the same approach? What about this? Have you seen the amount of edema around? Would you use this supraorbital mini craniotomy, or would you do a transcranial operation? If you do this small approach, you will have all this edematous brain coming into your field. So be judicious. How would you approach this giant pituitary adenoma, going supracellular, paracellular, encircling, invading carotid? How would you approach this? What is ethical? Would you follow the elitist endoscopist or the traditional transcranialist? So choosing the optimal approach, you have to be careful about the lesion. So you can do a supraorbital mini craniotomy for an aneurysm and a meningioma, skull base, and you can use the classical approach for aneurysm or supracellular meningioma, giving you a very nice open field where you can excise the dura completely and get a grade 1 excision or even a grade 0 excision. Learning is a lifelong journey, a never-ending endeavor. We keep learning from our friends, from ourselves. Make your own path. As Moses did when he parted the Red Sea, he made his own path. You make your own path. The third point is choice of technique. This was a young boy of 10 who came with this very large tumor in the frontal area. And typical traditional operation, what we do when we do a malignant tumor, we do a transsulcal intratumoral decompression and then you remove the tumor. However, I'm not going to show you this video. I did the same operation, but this patient bled and bled and bled. Even the arteries were all calcified. They could not be coagulated. So at the end, I had to stop after assuming some hemostasis. I could not remove the tumor well. I stopped. I did his post-op scan. And this is the high amount of glioma left behind. Post-partial resection. I was a little dismayed. I spoke to the parents of the child. I said, I'm not satisfied. I would like to have one more chance of removing this. I want to change my approach. Not go through the tumor, but go around the tumor. So they allowed me to do it. I went through, so instead of going a typical traditional transtumoral, intratumoral debulking, which we always do, which is recommended. But this time I changed, having learned from that first mistake. I went around. I should have learned that at that moment itself. At that moment, it didn't occur to me, but when I saw the scan, I said, no, let's do that. So if gross total removal is unachievable due to some intra-op difficulty, one could still regroup, replan, and reoperate so that you can achieve the surgical goal of total excision. There's no harm in making that statement to the patient's family. So I do stage surgery sometimes in a residual glioma. I don't have intraoperative MRI, but there are many other ways of knowing it. But if it is still there, it is worth reoperating rather than leaving the tumor behind. In a young patient, it can contribute to a long survival. So I did a stage operation. I re-explored. I won't show you the video, but this is what I did. And this is the result. Beautiful, complete removal. And in fact, the brain is now nicely collapsed. So coming back to minimally invasive neurosurgery, small exposures, but not unduly cumbersome. Reaching the lesion through the shortest and safest route is fine, with least trauma to the brain, least trauma to the cranial nerves and blood vessels. Great. So we say, keep it small and simple. KISS neurosurgery. So we say complexity and contradiction should make way for simplicity and consistency. So there's a revolution or evolution in neurosurgery by keyhole approaches, endoscopic extended skull base. So we say fads and fashions. Now today minimalism is in fashion. Be fashionable if fashion suits you. So be fashionable only if fashion suits you. Otherwise, you can still be traditional. Go to the next high risk factor, overzealousness. Again, my own case. This lady had a recent episode of one headache. And this was the MRI done after that. This was an MRI which showed a premotor area AVM. So I did an angiogram, I did a DSA and showed a very vascular high flow AVM supplied by the anterior cerebral, callosal marginal, pericallosal, both. I spoke to the patient's family. She was a young 27-year-old female, beautiful girl. I said, now this area is very close to the motor region. If she bleeds from there, if you go by the Aruba trial, they'll say, oh, she has not bled. Leave her alone till she bleeds, and then you operate. I don't know how many of you follow this technology, this ideology. I explained to the patient family that you can leave it alone if you go by that trial. I personally feel that I would like to remove it. Perhaps I was overzealous. But I felt that if she was somebody in my family, if she bled and got a hemiplegia, this hemiplegia may never recover. So is this a right patient selection? By Aruba trial, wrong patient selection. So I did an embolization, partial embolization, only could achieve this removal, and then I operated. I won't show you the tumor, the removal of the AVM, but I can show you the result. We have a pretty good removal, very nice, complete removal of the AVM, good circulation everywhere. But what about the patient? That is why I've used the word overzealous. This lady is fine. This is a post-op MRI. There's no more AVM. Angiogram is good, but she develops a little weakness in the leg from the supplementary motor area. Now, was I overzealous in doing this? Am I justified in giving a normal patient weakness? Mercifully, this weakness cleared up in 5 days because it was in the supplementary motor area. And post-operatively, she's absolutely fine and very happy. Before she goes home, she's already walking and standing on her toes. No weakness. So overzealousness is one aspect you have to be careful about. What about this? Lack of anticipation. We have to plan, as I said, keep on planning and preparing yourself. 27-year-old lady, again, my own case, headache for 1.5 years, double vision 6 months, right lateral lattice palsy. This lady had a tumor at a skull base, middle fossa, surrounding the carotid, paramedian location. Obviously, a chordoma, right paracellular chordoma. What would be the operation? Right subtemporal craniotomy, extradural excision. This operation was done by me about 20 years ago. And so here I am doing the right subtemporal operation, and I'm going on removing this tumor. Very straightforward looking tumor. Large chunks of tumor are being removed, and there is some spurting of bleeding. And I'm wondering from where, and there you are, a big hole in the carotid. I'm pushing some Surgicel, putting a large blob of cotton, stopping the bleeding immediately from there, compressing the carotid artery. I had not prepared myself. I asked my assistant, please go and open the neck, get hold of the carotid, and asked another guy floating around. I said, please call my interventionist immediately. So, what do you do when I see a perforation occurs? At first, control yourself, then control the bleeding. So I controlled myself. I put a cotton blob. I called my interventionist. He did this angiogram on the operating table itself. Fortunately, that operation table had a DSA. And this is a middle cerebral lifted up because of the cotton blob. And what he did was he put a coil embolization and a balloon occlusion of the carotid artery. Being a young girl, 27, she had very good cross flow, and that saved the day for us. We did our first post-operative scan, and this is what I see after 2 weeks. Still residual chordoma there. I again spoke to the family. I said, this chordoma, the treatment is complete removal. I cannot leave it behind. Now we have got a carotid secured. Let me go in again. I went in a second time. My carotid was safe. I re-explored her and totally removed the chordoma. And patient did well. Not only that, but she even recovered from her right lateral rectus palsy. But the purpose for showing this case was that I did not prepare. You can see this neck incision. We have prepared it afterwards. We did not keep our control on the carotid when you are operating in this. Lesson to learn. Next lesson to learn is wrong decision making. Should we always recommend surgery in every case? So consider surgery against the background of patient's expectations and his life expectancy, especially for malignant tumors, high-grade gliomas, secondary deposits. Choosing between what is good for the patient and what is good for you, the surgeon. For us, the surgeon, surgery often tends to be the first natural choice of treatment. Is that the right thing for the patient? So you must consider a wide range of treatment. Surgery is not the only way. Surgeons must know in their wisdom when not to operate. For example, butterfly gliomas, recurrent GBMs. I showed you this case of recurrent GBM. Attempting radical excision of skull base meningioma, which is encasing carotids. I showed you the case of chordoma. Infiltrating cavernous sinus. I showed you the carotid pituitary adenoma. Asymptomatic small non-growing tumors, benign tumors, especially in the elderly. You can leave it alone. They will probably not grow at all. So consider all these factors before you give the verdict of surgery. So here we are. This gentleman had a butterfly tumor. I said, sorry, I cannot operate on you. This is already far too spread. The family insisted and insisted. They came 3 times to me, and then they make a backdoor entry into the hospital. They admit the patient with a convulsion, and they said, Dr. Saab, aapko ye operation karna padega. You have to do it, otherwise this patient will die. Now I fell in this trap. So you see, we fall in the trap of this patient, trying to be good to the patient, actually trying to be kind is actually being unkind, both to the patient and to yourself. I did this operation. At least before the operation, this video shows that he was able to obey commands and moving his limbs. Post-operative, this is a scan. Okay, tumor removal seems to be good. Bifrontal craniotomy flap is removed. But what have I done to the patient? He doesn't even open eyes. Butterfly glioma, recurrent GBM, wrong decision making. Finally, technical reasons. We have MRIs, and I just want to put in a word of caution that you remember this MRI machine is a very powerful machine. It has 60,000 times the Earth's magnetic field. So when you are entering the MRI, you or your colleagues or your ward boys or your nurses, please be careful to follow. We have had patients where wheelchairs, trolleys, and oxygen cylinders have got sucked in. So there are MRI zone recommendations. Please follow this. So machines are used for our advantage. That had not become a disadvantage. But the technical error which I want to actually point out is this one. We did a good scan, we got a navigation protocol, and we took this patient up for surgery with a navigation protocol. So here we are. I put my parameters, I put my probe in, I take a biopsy. Good. Send it to the pathology lab. They said, nothing, normal brain. Oh. Second time, normal brain. Third time, normal brain. Fourth time, I went in all corners of the tumor. What do I do? This was the time when we said, somebody in my team came up with a brilliant idea. Why not use an ultrasound? We called the ultrasoundologist. We put in an ultrasound probe, and there we are. This was not the place where the tumor was. Tumor was 2 centimeters away. And why did this happen? The patient's MRI is done in supine position. This lady was being operated in a semi-recumbent position. Elderly woman, brain sag. And for some funny reason, inadvertently, my anesthetist, on a rare occasion, decided to give mannitol without talking to us. Brain sank further. All my parameters are wrong. I am not in the correct protocol. So, when we use the ultrasound probe, and then we got the tumor, and then we could remove the tumor completely. So we learn by making mistakes. Errando discitur. Errando discitur. We learn by making mistakes. I am now coming to the end of my presentation. If you must play, decide upon 3 things at the start. The rules of the game, the stakes, and the quitting time. So this is the quitting time for me. And before I quit, let me tell you, it is easier to stay out of complication than to get out of complication. So please prepare yourself, anticipate, and prepare and prevent complications from occurring. You know that we have already had 2 large international meetings on complications in surgery, International Conference on Complications on Neurosurgery, ICCN. Unfortunately, I know that I really miss my Pakistani friends from coming to this meeting. Both of them were held in Mumbai. And now we are going to hold the 3rd one. I hope the air clears up and we will be able to have you over in Mumbai. As I said, the highlights is anticipation, prevention, and management. ethical considerations, philosophical aspects, moral obligations, and legal implications. Everything is to be discussed. Frank discussion on pitfalls of management, how I would not do it rather than how I do it, and how I wish I would have done it differently. This is going to be an open forum of our failures and what we learned through them. Remember, failure is a defeat, only if you don't learn from them. So we have all these keywords in this new icon that we have prepared. This is a paperweight which I have prepared for this: anticipation, strategy, mistakes, pain, negligence, red flags, ethics, failure, team, danger. You can see all these words are connected to complications in neurosurgery. So be smart. Thank you very much. Dhanyavad. And before that, no, so we'll come to that a little later. What we are going to do is we are going to launch the virtual CME platform for complications avoidance in neurosurgery. This is going to be an interactive digital platform for the neurosurgical fraternity. I will put this later on our website. It's there on the website. And you are free to join in, and we can start this complication discussion on a regular basis. You just have to log in, you just have to register, and we'll be happy to have you, any one of you from any part of the world, discussing on this virtual CME platform. And you can bring in your cases even before complications occur to ask for opinions, and we can have several people pulling in to take part in this wonderful virtual CME exercise. So you are welcome to join us. Thank you very much, and I'm open to questions. I hope I have not taken too much time, Salman.
No, Keki, I think that was brilliant. We really enjoyed it. I'm sure Mumtaz, and we have 140 people listening to you, which is wonderful. And you took us through everything that a young neurosurgeon should know, the problems that we can have, and what we should be anticipating, and how to take care of problems if they develop. So there was a question to start with. I know you are very young and you're still running and you're very fit. And I know that you recently have challenged a friend of ours for a bodybuilding competition. I know that, but there's a question that when a neurosurgeon should stop operating.
Yes, I think that a neurosurgeon himself should decide. This is a plan that you should make preoperatively. You should decide what is the end point, as I put in one of my slides. What is the end point? You put my slide program. What is the end point of this operation? What is the goal of this operation? Do we want to remove the tumor completely? Do you want to leave that little bit connected to the artery or to an important structure, cranial nerve? Do you want to remove the acoustic completely and damage the face? Depends on your experience, depends on your team, whether you have got neuromonitoring to help you. And all these factors, there are numerous factors that will, your personal experience, your team experience, your infrastructural experience. And so this is something, and that you should discuss, because you have this mental exercise before the operation. You make this discussion with your family, with the patient's family, and with your team. And then maybe there are times when you have to stop earlier. Maybe there are times when you feel, no, I think I can still do a little more. And this very often happens. And you can get away with it at times. But there are times when you can land into trouble. So these are decisions which you have to make carefully. So we have a plan A, and then you also have a plan B. Plan B, which can be making the operation further, or plan B means terminating the operation a little earlier. This is a decision which every surgeon has to make depending on his own experience. As I said, there are two things required: knowledge and experience, which together form the big question of wisdom, what you saw in that small print in my slide. Wisdom is what matters.
We have a question from Adnan Khalik. He's from Pakistan, and he's asking, what is the experience using the awake craniotomy, tensor imaging, neuronavigation, brain mapping to avoid complications? Do you think it's worth it?
I think if our goal is complete tumor removal, maximum safe removal, let me put it that way. If our goal is that, then yes, we must bring in every possible facility. Awake surgery today is a very common thing. I've been doing it for 20 years. We have done something like 250 awake surgeries by now. Not too many. There are people who may have done more. And there are people who do awake surgeries just as a routine. Now I know Salim Abdul Rauf. He does awake surgery for basilar aneurysm. I've seen his videos. It's amazing. They do it for not only for gliomas, but for other things. I've done it for epilepsy. I've done it for skull-based tumors, very closely connected to cranial nerves. But I would say principally our operation on awake surgery is limited to those cases which are close to the eloquent area. And that means motor, speech. And speech area is not just one area. Speech area is Wernicke's, Broca's, and even the coordination areas. So you use maximum information available. You use the ultrasound. You use the your neuronavigation. You use intraoperative monitoring. And if our aim is to get complete removal, you keep the patient awake so that you are safe. And I would recommend reading today. Dufau's work is very well known. He talks about this, and I am also following for this attitude for the last, I would say, 30 years. I am not awake surgery, but complete removal or resection of gliomas, safe resection of gliomas. I've been doing it for 30 years, much before many people even talked about radical removal with nothing available, just by my own personal experience. So I would say that if this is your endpoint, maximum safe removal, then you must use all available facilities. And awake surgery forms a pillar.
Okay, there's Eriko from Bandung, Indonesia. And the question is, why use navigation for such superficial tumor where you showed navigation error? And if you did not use it, if you did not use the navigation, could you have a litigation associated with it?
Good question. Yeah, let me tell you, many of the times we are using navigation, me at my age today, I'm using it more for teaching than for myself. It is a very good teaching tool. As a result, we are spoiling our youngsters. Someday when you don't have the navigation machine working or the protocol available or the technician to do it for you and something like that, then you are stuck because you don't have that 3D imagination of how to calculate, how to mark your motor area, sensor area, all your indicators on the skull and on the brain. There, we have been used to reading the MRI and CT scan in a very careful way, much before navigation came. And I'm sure we were not regretting it. Today, we are using it only because it is very safe, it's very quick, and it gives you a personal reassurance. It's good for the team. And tomorrow, let us say, for some reason, you get a negative exploration. You think it's a glioma. Sometimes it happens. The brain surrounding the glioma looks like a glioma. And you are very worried about the motor area. And you send something, and a obliging pathologist will say, yeah, there is some gliosis. Maybe it's unfrozen. It may be difficult to say, but I will give you a diagnosis of a low-grade glioma when they read they try to oblige you. But yes, so in those instances, I think awake surgery and navigation can be extremely useful.
What about litigation? If you did not use navigation, could you have trouble?
You're right. This is exactly the point. And I had discussed this point once with Anthony Mendelo when I was visiting as a visiting professor in Newcastle upon Tyne. I went to their operation theaters and they had 3 rooms. And they said, this is something that we have acquired recently, a neuronavigation machine in every room. I said, we have just one. How did you? He says, no, every surgeon wants it today. And I'm talking about more than 10 years ago. Why? Because every surgeon is now scared of litigation. So he wants to use a neuronavigation, even though he knows he can navigate, but it is now mandatory. So yes, if you can have it, then use it. It's the same thing. People at one time used to talk about monitoring, awake surgery, all kinds of things. I've got a separate lecture on litigation. Time will not permit, but I can give you another 20-30 minute lecture just on these issues, if you want, at another time.
What is the permissible morbidity and mortality for a safe neurosurgeon? What would you say, what percentage would be morbidity, mortality acceptable for a safe neurosurgeon?
1%. Depends on the disease, depends on the lesion, But I would say you must look at your own records also. You must not go somebody, people, when I talk about complications, I have talked internationally to some very eminent luminaries in neurosurgery. People whom we worship, so-called. Oh, I don't have complications in neurosurgery. I said, then please come and tell me. Tell our audience how you don't have them. Come and attend the conference and just tell us how you don't have them. We would like to learn from you.
Okay.
False. Everybody has complications. Everybody has morbidity. Everybody has mortality. And you have to look at your own results and come up with that figure. That is why I said honesty. So when everybody comes to this meeting in ICCN, they come nude, open to everybody.
Okay. There is Dr. Yasser from Lahore. And his question is, why opt for complete resection of a tumor? Couldn't we have done a debulking and radiotherapy instead of a redo surgery on that patient?
Your choice, your ideology. I think if I think I can remove the tumor completely and give this patient even 6 months more, even if it is a high-grade glioma, which I can remove safely, mind you. Safety first. Then only you go in second time. That boy's tumor which I showed you was frontal. If it was a GBM in the motor area, I would not have gone in again, definitely. But just by giving him 6 more months and making him hemiplegic for the rest of his 6 months, no, that's not acceptable.
Okay.
Then, if I'm not answered, you can ask me.
No problem. So there is Ejaz again from Pakistan, and he's asking, my perception for awake craniotomy, awake surgery, is that surgeon should be awake, fully awake, and patient fully anesthetized.
Yes, it is true. Seeing how some of us are overworked, we can be half sleepy as well. But no, I think there are 2 ways of doing or 3 ways of doing awake surgery. One is that LMA, and there's a way where you sedate the patient, keep him awake, and again sedate the patient, or keep the patient fully awake. My technique is keep the patient fully awake, and you better be sure that you are awake as well. And make sure that not too many people are going to come in and out of the theater, and certainly nobody is going to make noise. We must be judicious. Patients are awake and they can listen to whatever you say. So don't talk anything stupid when you're operating. That's also important.
If you don't have a facility of a expert to come and do a DSA and embolize or coil or balloon, if you don't have that facility and you have ICA bleed during surgery, do you have any suggestions for that?
Yes, I will have to do an immediate ligation first to stop the bleeding, or put a trapping the carotid, and then do an immediate bypass. I have seen this patient's preoperative angiogram. I did not show it. She also had a good cross flow, and we have to presume that sometimes in a young patient that the cross flow is good, but it is a dicey thing, and I think it takes not much time to do an additional bypass, and you can do a very quick bypass. That's why when you're doing every craniotomy, you must, temporal craniotomy particularly, you must preserve your superficial temporal artery, because you never know when that will be handy.
Okay, there is
aneurysm surgery also. Yeah.
Okay. There is Asghar Khan again from Pakistan, and he's asking if there's a lesion in the eloquent area and you don't have the luxury of having different gadgets to remove this safely, what would you do? What's the is there any safe technique to do microsurgery and remove it from the mortal strip?
You go by a neighboring sulcus. If the tumor is very small, then of course then you have to use your ultrasound, and then you map the ultrasound during your exposure. You will know, you make a larger craniotomy, of course, so that you have the anatomy of the brain available to you. And then you see what is your local map of the brain, and you use your ultrasound. If ultrasound is not available, then you go by a neighboring sulcus and then try to reach the tumor following the MRI guidelines. But today, awake surgery is very common. And I would urge everybody to follow this. It is such a safe thing and such a simple thing. It is not done by only the surgeon. So awake surgery requires an equal partnership with the anesthetist. The anesthetists must be good, must be trained, must know how to give the sedation, how to give the blocks. There are 8 scalp blocks on each side, 16 blocks. Kya ho gaya? Ban ho gaya.
Band nahi hoga, you can carry on. We're just showing what we have for tomorrow and day after.
Okay.
Carry on, please. Yeah.
Okay. So yes, cervix surgery is something that is now pretty common. So I don't think one should have any. Haven't we done so many operations in the local anesthesia for emergency epidural hematoma? Do you remember? I have done them so many times. Emergency subdurals under local anesthesia. No anesthesia is available sometimes in emergency surgery. I'm sure all of us have done. I've done it many times. Not today. I've done it during my registrar days, during my young consultant days. Yes. So it's like a local anesthesia surgery. You can just do a local block if you don't know how to give. But scalp blocks today is not some rocket science. All anatomy books will tell you how to give it. You just see it once. There are so many videos to show it. You can learn it. Even if you have never seen another anesthetist doing it, you can do it. And I expect that even surgeons should know it, not only the anesthetist. It's such a simple thing, giving a local block.
Okay, then there is a question from India, and the question is that if you have had a complication, how do you manage that, and how do you manage the family? And if you have made a mistake, do you come out and tell them the truth, or how do you deal with it?
Yes. I wish I can put my next presentation. Salman, you can organize another presentation on that. It will be a very remarkable. It will be very nice to today is a very valid question and very you can say thematic problem. The point is, first of all, I think you must realize that no surgery can be said entirely safe, however trivial it may look. And therefore, you must be very, first of all, be nice to your patient, be nice to your patient's family, make them your allies, see that they are on your side, explain to them the problem, explain to them the disease, show them the scans, point it out to them, and even explain to them the approach, what you're going to do. This is what I do in my practice. It takes me 45 minutes, sometimes an hour with each consultation. But this time is good investment.
Okay.
And then I've had a 10-year-old child asking me these questions. Imagine. And the family wants the child to go out. No, don't ask, or you go out, don't ask these questions. So I said, no, it is his head. And he has a right to it. So keep the patient, make the patient your ally. That's the first important thing. And then see if there is a very bad complication, very major complication. Sometimes it is the error of the surgeon. It's not an error. It's a misadventure, or it's a mishap occurring during surgery. As you said, carotid artery tear. You must, first of all, everybody in the theater must have a common language. What are we going to tell the patient? What are we going to discuss with the family? It should not be that we have different versions of the event. And then the surgeon and maybe the anesthetist together, or the assistant, or the so maybe 2 or 3 people together as a team will go and talk to the patient's family. And this happens sometimes. I can tell you sometimes when we are having a large peripheral nerve tumor, and you know that you are likely to, it was a neuroma, but you thought you would be able to safely remove it, but now it is intermingled with fascicles, and you have to sacrifice some fascicles. Okay. What are you going to do when the patient is under GA? You have to go and talk to the family, or you stop the operation, close it, talk to the patient, and again come. But this communication is the biggest important point, most important point. Keep communicating with the family at all times, before, during, after, even if it means sometimes coming out in the middle of the operation. I have done that. It's not happening regularly, but do that if it is required to. Okay, it's a bad tumor, I have to stop. So you should, I think this is something that, and always be reasonably frank, if not entirely frank. You should be truthful to your patient. After all, he has offered his life to you. Okay. But I can give you a very beautiful PowerPoint presentation on this at another occasion, and we'll take about 20 minutes for that also.
Sure, definitely we do that. The other question is that do you use colleagues, or do you use friends, or do you use some other people at this time to discuss things and how to manage a situation when you're in a mess with the patient's relative?
Yes. Yes. So that also was there in one of my slides, but we had to rush through that slide. You can do that before the operation. You can ask a colleague, and you can even tell your patient that I have discussed this is a very complex case. There are many opinions, and sometimes you will come across such a thing where you will have divergent opinions from leaders of neurosurgery, where somebody will say, I will not touch it, or somebody will say, I'll do a partial removal, somebody will say, I'll do the maxima, I'll do bypass, and I'll do this and the other, but I'll get the whole tumor out because that is the goal of chordoma surgery or meningioma surgery. So you have to discuss maybe with your colleagues, and this CME webinar which I'm talking about, this platform which I'm talking about will be interactive platform. So if you are running in difficulty, you can quickly go online, and if somebody is there online, we can quickly review the thing and answer you on the spot. And we want to make this almost on an international level, so that at some time or the other, somebody or the other will be available once it becomes truly international. This interactive webinar will be extremely useful. So you can log in. The website is mins.thevcme.com. MINS is Mumbai Institute of Neurosciences. .the, that is the all capitals, VCME. V is virtual CME.com. And once you get onto this, you will have all your questions answered on this as well. And then you can log in, and we'll be happy to start this online virtual CME 24/7.
Okay, that's brilliant. As you can see, Nicolas Pive will be with us on Monday, in which he's talking about localization of lesions in spine, and this is especially meant for trainees and for people who are taking the exam or young neurosurgeons. And tomorrow, actually, we have a IFNE seminar, and that IFNE seminar is at 5 o'clock again. And on Sunday, we have Paulo Pereira. So we have 3 days in a row. We have these talks from PSN, and tomorrow is International Federation of Neuroendoscopy. So Henry Schroeder, along with Pepe Ginelli, and myself will be talking in that. So you all are most welcome. Okay, so there's another question here, and the question is, do you have any strategy planned for, especially for kids, when they develop complications? Do you have a separate strategy for kids when talking to their parents?
Well, I think that strategy remains the same. I know that kids occupy a special place in everyone's heart, and anything going wrong is really not kindly taken. My answer is still the same, that and that's why I said, if it's a reasonably mature kid, you can take the kid into confidence. I've done that. So let them be participant. But if the parents are very unduly nervous about it, they can keep the child out, and then we talk to the family the same thing as you would operate on any other individual. I don't think we have any different strategy for that.
Okay, Mumtaz, would you like to ask some question, please?
Yes, Turel, I think there are 2 or 3 questions, but the most important for me and the person who is asking the question, that is, shall we go for surgery in patient who has butterfly glioblastoma or glioblastoma multiforme at the corpus callosum area? This is the most important question. And the second was,
see, I would say, first, can I answer this?
Yes.
See, if your butterfly glioma is reasonably well defined and it is largely unilateral, not typical butterfly going to absolute extremes of both frontal lobes, then I would say you can go for it, because there is still a good chance you might help the patient, even if it is going across. The prognosis will not be the same as a unifrontal, but it will still be a reasonably good prognosis you can give to the patient. Okay, that's the first question.
Okay, how many times one can operate the glioblastoma multiforme if you are seeing patient with repeatedly recurrent recurrence? You see, this become a difficult situation for surgeons family.
You're right. I would say definitely a second time if they come in especially in a non-eloquent area, you can reoperate without difficulty. But if it is eloquent area, then the risk increases because the surrounding tissue changes, vascular changes. Previously, the patient must have already undergone radiation, so it is not an easy game. Also, I have myself operated on a couple of cases 3 times, but that is not what I would do regularly. But certainly, you must remember that between every recurrence, the first operation and the second and the first recurrence, and the first recurrence and the second recurrence, the time will become shorter. So the first recurrence may come after 2 years, let us say, hopefully. The second recurrence may come after 1 year. And if you are still enthusiastic about it, the next recurrence might come within 3 months. So I think you should again discuss that also with the family and say whether you really are interested in this, because so much time and money and energy will be lost in undergoing your adjuvant therapy. Your concomitant and adjuvant therapy, your radiation and chemotherapy will have to be administered again.
There was a question that how you remove the catheter, the balloon catheter, when you repair the skull base defect.
That Foley's catheter. It was just inflated and kept in place. It came out through the nose and we kept it there. Patient went with the catheter in his nose and we kept it on for 4 days, then gently deflated it for another day and out. And I just did another scan after 4 days and made sure that the patient was asymptomatic and then removed the catheter. I've done this catheter business 2 or 3 times. Once it was for a torrential bleeding from the skull base after a head injury, traumatic accident. And this patient was in a far off place. He was an orthopedic surgeon's brother. And he was in Aurangabad, which is about 200-300 kilometers from Bombay. And I was operating in my operating room in Bombay hospital. And it was evening time. And I was told that this bleeding is not stopping. And these people are pushing in blood and nothing. The nasal pack has been put by the ENT. It's not stopping. So at that moment, it occurred to me. I said, okay, you just push this one balloon inside blindly, Foley's catheter, and inflate it to the fullest. You can't even see from where the blood is coming because the ENT said, we cannot see. It's just full of blood. Can't even put an endoscope. At that time, I don't think too many people were doing endoscopy. And this was in Aurangabad. Anyway.
So, Salman, if you allow me, I must put 2 or 3 comments for Professor Turel.
Sure.
Turel knows that being a Muslim, today is Friday, and we have a very good sermon in the mosque. But due to Corona, you see, I must say that today this was a neurosurgical sermon for all of neurosurgical colleagues. And we learned so many points. Number one, that what you told me, I must add this is for the making format or for making a template for the neurosurgical colleague. So it is better to make the main points which you have narrated or which you have shown, and just listening and copying these points, one can make a good template from these, and then these template can be followed by our junior colleagues. The main advantage of these sort of meetings or I must say seminar is that we can't tell the junior or to colleagues how to operate, but at least we can give them guidance that it is better today I learned, it is better to stay out rather than to get out of complication. Still I'm confused. There are so many occasions you see that applying these formats in operation theater, it becomes difficult. When you are in the crisis, you see the format is on one side and then the natural behavior and the natural training style, it starts. So I must revise these few points that there was difference between the sequelae and the complication, the knowledge, wisdom, and the experience, they go side by side. The mistakes, of course, they are not allowed, but human error are, you see, they can be considered and they are permissible. Pre-operative planning is the main key to prevent the complication, and proper knowledge, you see, anatomical knowledge, examination, and of course the radiological thinking, the radiological planning, and educate training. These are the main points one can prevent the complication. Then you told us that the wrong choice for selecting a wrong patient and selecting a wrong approach and selecting a wrong technique that can make a complication. And one thing I learned from my senior as well, that if you add neurology after surgery, it means the approach was inappropriate. So this is from my side. And you see the learning is a long course and it is for the lifelong, you see, and we must take care and we must include this. Then you told us that, of course, the fashion and the tradition, I must appreciate this words, because if you can spend life in a modern world, it is better. But you should have a style, a physique, you see, and all the necessary thing for the patient. Otherwise, traditional life and traditional neurosurgery is better than minimal neurosurgery. The technical reason and the errors you told us, and in the end, I must say that the failure is a defeat, and we must, you see, try to defeat this failure, and we must work for our patient to give them a healthy and useful life with the quality. And from Peshawar and from Prime Teaching Hospital, I must say thanks that you have spared time and you have shared your valuable, you see, experience with our colleagues. Thank you very much. Salman, if I have taken extra time, so
no, it's fine.
Thank you very much. Thank you very much for this hosting this wonderful occasion. This is truly delightful. I cannot have words to thank you and Salman both. And I once again want to emphasize that please let me know those who are interested. We will arrange to register and you will get the confirmation on email for this virtual CME whenever you want. And you can post your questions also on it and we'll be glad to answer them. All right. So thank you. And we hope to meet again, inshallah, sometime very soon.
Yeah, definitely, Keke. Yeah, we are looking forward to that. I was hoping that we could, I was talking to Atul and I was saying, let's maybe have a joint meeting of neurosurgery and Indian neurosurgery together, Pakistan, Indian, and the whole idea is to maybe have 3-4 hours of session with different topics. And, hopefully, since Atul is the president as well, so we should be able to get things going. We're looking forward to working on that. In the meantime, as we said, we have a very interesting week coming up. We have some interesting talks as well for the next week as well. And we'll keep that posted on our Facebook page, which you can see, which is already there. And I think everybody has that. KK, it was wonderful seeing you, and it's good to see you. You're still only 16. And you're keeping smart as always and full of wit, which I really like. How's the photography coming along anyway?
Oh, fantastic. Can you see some pictures in the background here?
Yeah, amazing. I think you're doing a great job. Definitely, I think a trip is on for Mumbai. Don't worry. Okay, take care of yourself. Thank you, everybody. Thank you for joining us. And we hope to have you in a fortnight or something again.
Thank you.
Inshallah. Thank you.
Thank you, everyone.
Thank you.
Bye-bye.